Hello, my name is Dr. Wood Pope. I'm an orthopedic surgeon here at OrthoGeorgia, specializing in shoulder, hip, knee, and foot and ankle conditions. Today, I'm going to talk to you about some common shoulder conditions that I see in my practice. The biceps tendon, it runs down the front of the shoulder and is a very common source of anterior and superior shoulder pain in both the young and aging patient. Now, in the younger patient, this is typically a overhead throwing athlete or overhead athlete that has trouble initiating overhead activity. This pain will be exacerbated by that movement, oftentimes lifting weights, and there are certain maneuvers we can perform in the office to isolate that biceps tendon to elicit pain and predict pathology. Now, your biceps tendon has an attachment distally in the elbow at the radial tuberosity. The muscle belly is in the mid-upper arm, and then it will diverge into two tendons. This model has a long head tendon, which comes through the bicipital groove. The bicipital groove is an area in the shoulder between the lesser tuberosity, which is the attachment site of your subscapularis muscle, one of your rotator cuff tendons, and the greater tuberosity, which is the attachment site of the supraspinatus and infraspinatus rotator cuff tendon. This long head of the biceps goes through this bicipital groove. More distal in the shoulder, it does have an accompanying divergent short head tendon that attaches to the coracoid, which is this bony knot right here on the front of the shoulder. This long head of the biceps will then enter the shoulder between the upper border of the subscapularis muscle and the anterior leading edge of the supraspinatus rotator cuff tendon. This biceps will then enter into the shoulder and attach to the glenoid labrum. This labral structure is a circumferential structure around the shoulder socket. This biceps tendon can develop tendinitis or even partial tearing within its intra-articular portion. It can also detach the labrum such that every time you use that biceps tendon, it will further pull and tug this labrum away from bone. Both of those are very painful conditions and will typically hinder you from throwing, working out, sometimes even sleeping comfortably at night. So most patients present to me with shoulder pain, sometimes with activity, sometimes at rest, mostly anterior and superior in nature. We typically see these patients in the office. We do get an accompanying x-ray to evaluate the ball and socket joint to ensure we don't see any traumatic fracture or bony pathology of the ball and socket joint. Unfortunately, the labrum, the biceps, the rotator cuff tendon is not imaged at all with plain x-ray. We typically then will examine you. As mentioned earlier, there are certain specific tests that we can isolate both the biceps tendon, the labrum, the superior labrum, as well as the rotator cuff. If there is suspicion of tendon tearing or labral tearing, an additional advanced imaging study known as an MRI is frequently ordered. This is essentially a high-tech x-ray that looks more at soft tissue structures than bony structures. Those studies typically take about 30 minutes. Oftentimes with biceps tendinitis and partial tears, or even small labral tears, we can manage this with anti-inflammatories, occasional injection, and physical therapy. However, sometimes these conditions remain persistently painful and do require surgical fixation. If you feel that you have a biceps tendon pathology or a labral tear and need further evaluation, please do not hesitate to come see us at OrthoGeorgia.